worried about her schedule for next semester. So I apologize for the distraction. I still set my phone down to the side and not pay attention. Don't text me if you need something, because I'm not gonna pay attention. Okay, you have to put it in the chat or Red's gonna talk to me. Okay, so today we are starting pediatric neuro. And where to begin with this? It's gonna be similar to cardiac, but not as challenging in my mind. The main thing with neuro is understanding your assessments, okay? You need to know your assessments of the neurological system and as a whole. And milestones are a big one with this, because if they have a neuromuscular disease of some sort, we need to be gauging milestones. So again, review back to growth and development so that you know your milestones. Because if there's a test question that says a 4-month-old can't smile, a 9-month-old that isn't crawling, or whatever, you kind of need to know what is expected and what they can or can't do at those ages. Because if they're not doing those things, then that alerts us to a problem. Okay? So, alright guys, I will tell you that next semester, we're doing things differently when it comes to the work guide and when it comes to slides and PowerPoint, so that everybody can be aware right now, your lecture content will be posted 1 week before your lecture on Blackboard. You won't be getting the giant work guides, okay? And some of us will not do PowerPoint presentations because some of us like to show our faces. Some of us do outlines, and some of us do Prezi, and some of us do whatever else. So just be aware of that, that there will be a change next semester. I know y'all are all so excited about it. I can just see the joy in your faces.
What do you change in the last semester?
I didn't add any wonderful things to encourage you today. Like, I'm going to read these slides word for word and expect you to know everything for the test. I don't have any of those pretty. Maybe by Thursday I'll do that, but I haven't done that. Oh, and one more thing. Before I get started on lecture, the blueprint will be printed by 6 p.m. or on Blackboard by 6 p.m. tonight. Do not expect it before 6 p.m. tonight. I will post it by 6 p.m. tonight. If you're looking for blueprint, don't expect it to be there till 6 p.m. tonight, okay? I'm still working on test questions, and so Dr. Hicks and I are ironing out the test, so that's going to be a little bit later before it gets posted today, all right? So just throwing that out there so everybody is aware, and I don't want to send another announcement, so I'm telling you verbally. Okay, neurological questions. Again, recognize that anatomy and physiology of the neurological system. We have the central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which has our sensory and somatic different types of nerves that are there, okay? And then we have to really focus in on your assessment, okay? So you see several slides here about assessment and what to know and what to look at and what to look for. And we're going to go into even descriptive terms for what they mean and what they are, what they look like, so that you have a good understanding of a neurological assessment, okay? So we want to look at their cognitive function. What does cognitive mean? Anybody, what does cognitive mean?
Process.
Good. Their ability to think, right? Cognitive. Their ability to think. So, when we assess their cognitive function, how well can they observe their surroundings? How observant are they? What is their behavior? Do they have poor impulse control? Do they have thought process that controls their behavior? Are they able to do that? Are they potty trained? Right? That's a behavior. Have they learned or reached the point point of cognitive function, or should have, if they're potty trained, right? Communication, can they talk? That's a thought process. You have to think and be able to form words before you can form words. Let's see. Communication, we said that. Memory. Where are they at in their ability to remember? Can they remember object permanence? Where are they at with that? Remember, with your infant, when is object permanence something they can do? And when can they remember more things, more words? Words are memory as well as observation and behavior. They have to observe what that word means and then be able to say it back to you, knowing that that's what they mean. So if they're saying, I want to eat, they need to know and observe what eat means, right? They need to be able to say it, and they need to remember what it means, okay? And then level of consciousness. We all have a good idea about level of consciousness, but it's important that you think about with an infant, what does that look like, okay? And we're going to go through some of that as we get a little bit further into this. Cerebellar function, that is what regulates balance, coordination, and gait. So can they walk? Can they stack blocks? Think about your growth and development assignment. Guys, we gave you that assignment to help you recognize where children are and what can they do. Can they draw a circle? Can they draw a square? Can they stack blocks? Those are all things that we ask you to assess and look at and know, because when it comes to this assessment, you need to be able to assess whether they're able to do that or not. Reflexes are really big in your infant. Do they still have reflexes they shouldn't, right? Or do they have reflexes they should? Do they, are there reflexes, because some of them, that they grow out of them, right? And so have they grown out of them, or do they still have them? Some of them they don't have, but they get later. Do they have it? And they shouldn't. So those are another thing, and we're going to talk about some of that as we get further into it, but those are things that we assess, especially in children. Their head is another big thing for us because we're looking for increased intracranial pressure and the signs of increased intracranial pressure. So we measure the head circumference and we look at their sutures and fontanelles. Another thing that's real prominent since we've gone to the back is best. We have a lot of kids that are getting malformed heads, and so they're putting the helmets on them. I know there's a name for that, but it's not coming to me right now. But we assess those things, and we look for things, and we look to make sure their fontanelles are where they should be, and are they open, are the sutures given, are they sunken? That tells us if they're dehydrated. Are they bulging? That tells us they've got increased fluid. Those types of things. So we're going to look at their head circumference and their fontanelles and sutures. Up to the age of 5, a child's head circumference can increase with increased intracranial pressure. After age 5, then there's less concern with the circumference of the head because the skull has reached its maturity and everything is a closed box at that point. Okay? But up to age 5, the head circumference can still enlarge with increased intracranial pressure. So we're going to look, when we think about symmetry, their face, their mouth, their ears, we're going to look and assess all of this is listed here. Perlap. Now recognize this perlap. What is accommodation? What does that look like when you assess it? Somebody talk to me. What does accommodation look like? Where do you have them look first with accommodation? Okay, and then you have them look where? Say it again. I didn't hear you. Back to what? Oh, to your pen or to your finger? Right. So accommodation is where you have them look off to a distant corner or a distant object, And then you hold your finger or your light pen, whatever, you tell them to focus on. So you say, okay, look over there in the corner and then look at my finger. Or look over there and look at my finger. Okay, and then you watch for the eyes to constrict as they come back and look at the finger, right? So, if they can't follow directions, then you measure accommodation. So, if you're looking at an infant's eyes, would you put curl in documentation? No, right? People equally round, reactive to light and accommodation. Well, if you can't do it accommodation, leave that A off, right? So think about those things with assessments and what they can and can't do. Cornea, blink reflexes, signs of Down syndrome, we're going to talk about that more. The history or risk factor for hearing loss. And some of that's going to come from maternal infections and those types of things. Gag and swallowing reflexes, sucking reflex, excessive drooling, and tongue deviation. These are all things when we're looking at the face, the mouth, and the ears, we want to make sure that, and eyes, that we're assessing and looking for. So,
Picture capture or Zoom recording on?
yes. Yes. We're good. Sorry, I didn't tell you that, but yeah, I did. Okay, so with neuromuscular, we want to look for symmetry, which means what? What's symmetry mean? Equal, right? So we're going to look for the symmetry of their body. It could be the symmetry of their eyes, the symmetry of their ears, it could be symmetry of their hips, okay? It could be symmetry of their arms hanging down. Everything needs to look balanced. And we also want it equal. So we're going to look at the strength of their movements and the strength of their extremities. Is it equal? When they squeeze our hands, when they push on us, when they do those things, is everything equal? Head lag. Do they have head lag past the point of when they should be able to lift their head? Right, so that's lifting the baby by their arms, and does their head hang down or do they hold it up, right? So head lag and the ability to hold their head erect, and then the Neuro reflex. So make sure that you know what those are, and developmentally when they should be able to hold their head erect, when that head lag goes away, and the Neuro reflex. Okay? And then sensory experiences. So do they know if it's day or night? Can they see? Orientation, do they know where they're at? Auditory, can they hear? Sight, can they see light, smell? Even infants know when they're with their mom, even if they can't see or hear, right? Because they can smell. And certain people have certain odors and they like the smell of that. Taste and touch. All of these sensory experiences we need to test and analyze if we have a child that we believe has some neuromuscular issues or deficits. Okay, we need to be looking into them and recognizing and being able to analyze whether they can have those sensory experiences or not. So abnormal neurological findings are going to be, they're not doing what they're supposed to. That head lag is lasting longer than it should. Delayed skills. They're not smiling at 4 months old. They're not rolling over when they should be. They're not crawling. They're not walking. All of those skills that they should be doing are delayed. Okay? And that also includes speaking. Okay? If something is wrong, the development of speech, they have a cognitive impairment, we'll have a delay in speech as well. They'll have a persistent reflex behavior. So the reflexes that are supposed to go away at a certain time are still there. These babies have a very high-pitched, shrill cry. Okay? If you have a baby with a problem with their brain, or if they have increased intracranial pressure, their cry will be extremely high-pitched and shrill. Okay? It's not like just a regular baby cry. And I'll try and pull that up when we go to break. I didn't have the chance this morning to get all that ready, but I'll try and pull it up so you can hear it, okay? And behavior disturbances, Sometimes children that aren't growing appropriately or they're cognitively impaired, and they will have some issues with behavior because they don't understand what's going on around them, and so they're confused, or they're frustrated, or they're just not sure how to process the information. It's overwhelming for them, so they'll act out. Changes in the LOC. Seizures are not normal. The misfire in the brain, that's not normal. So if we have seizures of any kind, we know we have some form of neurological issue. It may just be they have a really high fever and they have seizures when they have high fevers, and that could be all it is, but still, it's not normal. Change in pupil reactivity. So if their eyes aren't reacting to light appropriately, then they're either constricted when they shouldn't be, or they're blown either way, we have an issue. If one reacts and the other doesn't, we have an issue. And then pain is a neurological finding. Why would pain be a neurological finding? What do you think? Pain is. Why is pain a neurological finding?
Because it has to do with your nerves.
It has to do with your nerves, right? If you didn't have nerves wherever you were hurting, then you wouldn't have pain. So not only is pain an abnormal neurological finding, but the absence of pain, a child that does not feel pain, is also an abnormal neurological finding, right? If you pinch a baby, what do? They cry. If you pinch a baby and they don't cry, or you poke a baby and they don't cry, then there's an issue. And that's not good for that baby, because pain protects us. If we can't feel pain, if a child can't feel pain, they have a hard time learning things they shouldn't do, because the consequences that usually are pain are not there for them. And so they get injured a lot more, they have a lot of issues. So absence of pain is also an abnormal neurological finding. Neurologically, our lab and diagnostics, CBC, CMP, recognizing that if there are changes in the fluid and electrolytes, there are going to be issues with mentation. If they're retaining CO2, we're going to have issues. If their blood sugar is low or extremely high, we're going to have issues, right? So if they have infection, that can affect your brain, and fever and all of that. So CBC and CMP for your labs are good to know your norms on. General x-rays help us if we've had some form of traumatic brain injury, blunt force trauma, something that's affected their brain or their spinal column. CTs and MRIs give us much more detailed information. EEG is electrical conductivity from the brain. And EMG is another one, which isn't on there, but that's another one which tells us how well the muscles are firing and the nerves are firing within the muscles. So an EMG should be added to that as well. EEG is brain waves. A lumbar puncture is going to tell us if there's pressure or increased intracranial pressure. It's going to tell us if there's infection in the spinal column or in the cerebral spinal fluid. Extensive history. We know that drugs and alcohol have affected infants. We know that maternal infections can affect infants. So not only the history of the child, but the history of the parents, the history of how was the baby born, any issues with delivery, those types of things, any infections. Did the mom have gonorrhea when she delivered the baby? Was the baby delivered vaginally? All of those things, extensive history, okay? Have they had their immunization? Has the mom had her immunization? Because there are disease processes out there that cause deafness. And so we need to make sure that the baby's protected to prevent those diseases that can cause deafness, okay? Drug screening. There have been children that have been found in drug houses that are high on cocaine or drunk or meth or whatever, if they're exposed to those things, then there's a risk for them to have issues with drugs. And then also, we're gonna look at auditory and visual potential tests. So if for some reason we believe they can't hear or see, then we're gonna follow up, and that's what that's saying. Okay. Page number on this one, I think I do. All right, it's chapter 30. I have a box number, but not a page. 1113, page 1113. So, let's put it down a minute. All right, guys. So level of consciousness is our most important indicator of immediate change in neurological dysfunction. Okay? Level of consciousness is what tells us if they're okay or not. You want to know if they're conscious or unconscious. Are they alert? Do they react to stimuli? And then can they process data? Can they answer questions? Can they take in what's happening to them, right? Process data, processing of data. What's happening? What's taking all of that in is processing data. Does that make sense? Looking around and saying, oh, I'm in a hospital, versus at home in my bed. Processing data. So there are multiple levels of consciousness that are listed there. Alert, confusion, delirium, obtunded, stupor, and coma. If you look at page 1113 in your textbook, box 30.4, full consciousness would be alert. And then it gives you definitions and has a few others. So page 1113, box 30-4, will define all of those for you. I would be familiar with page 1113 in your textbook. I would want to know the definitions of the different types of consciousness, as well as the use of the, I always say it wrong, Glasgow coma scale, whatever. But that pediatric coma scale that's on page 1113, I would be familiar with that. So if they're unconscious, that's obviously a deviation in altered LOC. Seizure disorders is a change in LOC. Increased intracranial pressure. And recognize that these altered LOCs can be caused by a multitude of causes. Multiple causes. This is just a very small list of what can cause changes in LOC. Trauma or injury, so they've been hit in the head, or they've taken baby syndrome, or something along those lines. They've fallen from a parent's arms to the ground. They've fallen out of a tree and hit their head. Whatever. Trauma or injury. Hypoxia. So if they have had a lack of oxygen, which may be attempted suicide, or maybe a submersion, a drowning, those types of things. Could be a lung issue. Could be they've swallowed something. Right? Hypoxia. Infection. I bet Ms. Briggs talked a little bit about infection changing your LOC in children, right? She talked about it causing high fevers, causing seizures, right? So poisonings, lead poisoning is one that we look for in older homes, and it can change children's behavior and ability to think. There are other types of poisonings, but that's the one that comes to my mind right away, and I do know that it causes developmental delays. Seizures. Think about your post-ictal state, and even during the seizure, they're not alert, they're not aware, and then even after, it can take a little bit for them to come to, and for them to become alert. They can be very drowsy, very lethargic, very attentive even sometimes. So endocrine or metabolic disturbances, electrolyte or acid base imbalances, and then congenital structural defect. So when we talk about that, we're going to think about congenital structural defect. We're going to think about your neurotube defects. Okay, we're going to think about that's a congenital structural defect that can play into issues with altered LOC and neuromuscular ability. Again, back to assessment. These are all, yeah. So orientation, cognitive functioning, responsiveness to environment or stimuli, and pupil size and reactivity, movement of extremities, ability to maintain an airway, changes in vital signs, changes in breathing patterns, status of the cranial nerves, and we're going to talk about cranial nerves, and the Glasgow Coma Scale. Glasgow. How do you want to say that? So your coma scale, if you look at that, actually goes through all of those things and assesses those, gives you a number to relate back to tell you a number according to what their coma scale is. The highest a person can get is a score of 15. Anything below an 8, from 8 or below, is accepted as the definition of a coma. And usually when you get down to a 3, they're dead or dying. So we want to make sure that we're doing this assessment frequently. Children can change in an instant. They can be fine 1 minute, 20 minutes later, they can have increased intracranial pressure and really be having troubles. So we need to be assessing them frequently when we know that they have a brain injury or infection or something that can affect that immediately. So that's why when we have the potential for a when they have deterioration, they need to be assessing. They may start out awake and alert and respond, and then the next thing you know, they're not confused, and then they get restless or fussy or irritable, and then drowsy, but they'll still respond. Yeah, it's a sequential pattern. And when you have a deterioration of neurological status due to an injury, infection, or something that causes that change right now, this is what it's going to look like. This is the progression from alert and oriented down to coma. Okay? Down to death, actually, when there's absolutely no response. You can see posturing on page 1116 in your textbook. It shows a picture there of posturing. Gives you an idea of what that looks like. There's also really good, and that's figure 30.4, page 1116. There's also one about pupillary changes on page 1115. And it gives you a really good look at what that looks like, as well as definitions. Okay.
What figure was that?
Yeah, page 1115, figure 30.3. That's going to be your eyes, your pupils. So when they're considered unconscious, it's a state in which the child's cerebral function is depressed, and it can range anywhere from stupor to coma. Again, refer back to pages 1113, so you know what that means. And then we want to continue to do our assessment. We're going to check their neurostatus, and everything that I have just gone through with assessment, right? Those are all things when we're doing focused neuroassessments we need to be evaluating. And then the Glasgow Coma Scale or the pediatric coma scale that's there. I missed it. One of the things I want to point out with the pediatric coma scale are the age ranges on verbal response. Okay? Look at your age ranges. They're even, well, all of them. The eye opening is going to be a little bit different, but not as much. And if you look at the one in the textbook, so whatever scale you have at your facility is the one that you use. But generally speaking, they have age ranges. They have things that you look at when it comes to verbal response or response to pain, those types of things. Whether they can follow commands or not, depends on the age, right? So take a look at the graph. This is just one. There's also the one in your textbook. Be familiar with how to use one of these scales and to look at it appropriately, recognizing your age ranges and those types of things. Okay? If you are a knowing others type of person, then I would suggest thinking up an assessment of a child and walking through it using this. We can do some case studies. I have not put an assignment out for this one yet. If I do, I'll let you know, or I'll tell you on Thursday. Okay? So take a look at that and be familiar with it. So what are some interventions that we do across the board neurologically? Now, look, your textbook does say CAD, okay? Recognizing that over time and with CPR, that has changed to circulation, airway, breathing. We still want to prioritize airway because a lot of times if we don't have an airway, we go into respiratory arrest, which leads to cardiac arrest, right? So yes, we need to make sure we have adequate circulation because if we don't, our kidneys won't perfuse, our brain won't perfuse, and we have issues, right? So we need to make sure we address that. But we also want to make sure we're managing the airway because if respiratory drive is suppressed or we have an issue with respiration due to fluid electrolyte changes or whatever, that's going to affect our mentation. Hypoxia is one of those things that changes LOC. We need to maintain that patent airway. A person's having a seizure, we want to make sure that they maintain their airway, those types of things. Monitor their vital signs. Thermoregulation. Okay, when you have a patient in a coma, or you have a patient that has altered LOC, they can have issues with thermoregulation. It depends on what area of the brain is affected, but they can have very high temperatures. A lot of times that's what you'll see, there's some issues with thermoregulation and they'll have fevers. Okay. Manage bladder and bowel elimination. We don't want them to get bed sores or have issues if they can't control their bowel and bladder. Maintain hydration and nutrition, so we want to make sure that we have IVs, and we may end up with an NG tube or a PEG tube, depending on how long their unconscious or state of consciousness will change. We may also use TPN if it's a short-term thing, but we need to make sure that they're getting good nutrition, because if they're not, their brain may not heal. They need that protein. You can't just give them sugar water and expect them to get better. They need to have protein and nutrients. Provide proper hygiene and skincare, again, turning every 2 hours, watching their skin, position, spine stabilization, and performing exercises. So all that kind of works together. If we have an issue with their spine, we want to make sure we're maintaining that spine alignment. And we may not be moving them or doing exercises because we don't want to cause any movement in the spine. But if that isn't related to their spine, then we do want to do passive range of motion so that they don't get contractures or don't have issues with atrophy because they're not getting used while they're in the state of unconsciousness. Okay. We may have to use ophthalmic ointment or patches if their eyes don't fully close. We want their eyes to close because if your eyes are open all the time, they get dried out and have issues. And we may even have to put some ointment in there. We need to be assessing their eyes if they're unconscious making sure that the patches aren't too tight or too heavy, making sure that their eyes are staying hydrated and using the ointment and patches as needed. Pain assessment, if they're unconscious, we're going to use a scale that helps us to determine pain when they're unconscious. Okay? And then medications, we may be giving them medications to reduce increased intracranial pressure, so mannitol. We may be giving them some pain medicine if we're finding pain. Even if they're unconscious, we don't want them to be in pain. Do we have to make sure that the sedative effects of the pain medication don't add to the unconsciousness? Yes. So how do we monitor some of that? What's one of the reflexes that we monitor to know if someone's had too much pain medicine?
They're breathing.
I heard it.
They're breathing.
Breathing, yes, very good. So respiratory rate, make sure that their respiratory rate is adequate. And then educate, you got parents here, and these are kids. These are not adults, these are kids. So, and that's the other thing. Educate the parents and provide support, provide resources, think about any support groups, things like that, that you may want to refer them to depending on the cause, and a lot of different, there's a lot of different organizations that are out there to support changes in neurofunction, people with traumatic brain injuries, things like that. And recognize that sometimes these they happen when they're young, and then they continue throughout their life, okay? If they've had a traumatic brain injury, there's going to be changes in recovery, and the person with a traumatic brain injury for the rest of their life will have issues with impulse control. They'll have some changes in ability to understand and grasp cause and effect. I have taken care of patients and family members. I have family members that have had TBIs, and throughout their lives, they continue to have some of these same sensory deficits that came from their injury when they were a baby or when they were a teenager, those types of things. We had a young man in our community that had a horrible traumatic brain injury off of a longboard fall, and took him a long time, probably a year to recover, and he still has some issues with impulse control. So I've taken care of a number of patients through that same issue. So we want to make sure we're supporting the parents, and we're helping them to assess what they're able to do and what they can't do. Some parents have the resources to be able to bring a child home and care for them in a vegetative state or unconscious state, and some parents don't. They just can't make it happen. So we help them to evaluate resources and what they can and can't do, okay? And we want to support them in their decisions. All right, increased intracranial pressure. Let's see what time it is. Let's take our 10-minute break, guys. Let's go ahead and take our break, and then we'll come back and answer